diagnosis. The antibody titer against Vibrio cholerae O1 rises and remains positive in such carriers as long as they harbor the infection. This method is preferable along with bacteriological examination of stools. For host factors. All ages and both sexes are equally susceptible to cholera. Gastric acidity is an effective barrier. Vibrio is destroyed at a pH 5 or lesser, and hence conditions which reduce gastric acidity may increase the susceptibility to cholera. Population mobility, that is, people participation in pilgrimages, fairs, marriages, increases the risk of contracting cholera. Economic status, the incidence is highest in the lower socioeconomic strata. Immunity, an attack of cholera confers some immunity, but the duration is not known. And vaccination also gives temporary immunity, and that too partial, for 3 to 6. Environmental factors which facilitate spread of cholera are poor environmental sanitation, contaminated water and food consumption. Flies may carry vibrios, but their role has not been proven. Low standards of personal hygiene, illiteracy, poor quality of life, habit of open defecation have been associated with increased risk of cholera. How is cholera transmitted? Transmitted through fecal contamination of water. For example, water in lakes and ponds, rivers, etc. if contaminated and used for drinking directly. Contaminated foods and drinks. Fruit and vegetables washed with contaminated water. Cooked food may get contaminated through the contaminated fingers and flies. Through direct contact, that is person to person, through contaminated fingers while handling contaminated linen and fomites, etc. What is the mechanism of diarrhea in cholera? That is, how is diarrhea caused in cholera? You can see there's a thick layer of mucus on the intestinal epithelium. The Vibrio cholerae secretes mucinase, which dissolves mucus, and then the Vibrio cholerae multiplies inside the lumen of small intestine and secretes enterotoxin, which has a light subunit and a heavy subunit. The light subunit attaches itself to the epithelium and attaches the bacteria to the epithelium. The heavy subunit stimulates the adenyl cyclase CAMP system of the intestine, which leads to secretion of copious amounts of fluid into the lumen of the small intestine. This fluid is isotonic with body fluids and is the cause for diarrhea and vomiting. Clinical features. We will describe a typical case of cholera which consists of 3 stages. These are stage of evacuation, stage of collapse, and stage of recovery. Stage of evacuation. Abrupt onset of profuse, painless, effortless, watery diarrhea, followed by vomiting. The rice water appearance of stool is characteristic. Person may pass as many as 40 stools a day. There is so much of secretion of fluids into the lumen. Second stage is the stage of collapse. The collapse is because patient soon passes into collapse due to dehydration and acidosis. Clinical signs are sunken eyes, hollow cheeks, scaphoid abdomen, subnormal temperature, washerman's hand and feet because of dehydration again, absent pulse, unrecordable BP, loss of skin elasticity, shallow and quick respirations due to acidosis. The output of urine decreases and may eventually stop. Person may be restless, experience intense thirst and cramps in legs and abdomen. And death, if occurs, will occur at this stage due to severe dehydration and acidosis. Third stage is stage of recovery. If the person survives the stage of collapse, begins to recover. Blood pressure begins to rise, temperature returns to normal, urine secretion is re-established. In some cases, if it is not re-established, it means the patient has gone into anuria and renal failure has set in, needs to be managed in an emergency. The classical forms of all these stages, 3 stages, occurs in only 5 to 10% of cases. Mild cases recover within 1 to 3 days, and with LTOR, 90% of infections are mild. The LTOR biotypes differs from classical biotype in the following. With LTOR, there is a higher incidence of mild and asymptomatic infections. There are fewer secondary infections, fewer secondary cases in the affected families. There is a tendency towards chronic carriers and physically more resistant than classic biotype. They survive longer in the extra-intestinal environment. The diagnosis of cholera can never be made certainly based only on clinical grounds. There is a need to collect stool sample. A fresh specimen needs to be collected, and that too before starting the antibiotics. The stool sample can be collected using a rubber catheter or a rectal swab. Rubber catheter should be sterilized by boiling before introduction, and the voided specimen through the catheter may be collected directly into the transport medium. Alternatively, rectal swab can be used which has been autoclaved, and the absorbent cotton has to be dipped into the holding medium before introduction into the rectum. If it has to be put directly into the transport medium, if transport medium is not available, the swab can be packed in sterile plastic bag and sealed tightly. Vomitus is practically never used because there are very few chances of isolating Vibrios from vomitus. For examination of the suspected water, if filter method has to be used, we need 1 to 3 liters of suspected water which is collected in sterile bottles. Other method is to add 9 volumes of suspected water to 1 volume of 10% peptone water and send to the lab. Suspected food sample needs to be collected. About 1 to 3 gram of the food sample are collected in transport media and sent to the lab. For transportation of the stool sample, sterilized McCartney bottles 30 ml capacity containing alkaline peptone water or Wenger-Truman medium are used. For rectal swab, alkaline peptone water or Kerry-Blair medium can be used. For this, The top of the swab should be broken so that it fits into the tube containing the medium, and the cap can be replaced. If suitable plating media is available by the bedside, the stools can be directly streaked and forwarded to the lab along with the above samples. For identification of Vibrio cholerae from the specimen, dark field illumination microscopy can diagnose within 80% of cases within minutes. In the dark field, the vibrios can be seen like shooting stars in a dark sky. If this motility ceases on mixing with polyvalent anti-cholera serum, the organisms are presumed to be Vibrio cholerae. The samples can be cultured in the following way. The specimen in the holding fluid is shook well and inoculated onto the peptone water tellurate medium, which is incubated for 5 to 6 hours, and a loop from this is subcultured on biled salt agar medium, which is incubated overnight, and the plates are observed under oblique light illumination and further tests are carried out. Characterization of the isolated bacteria are done by gram staining, observing motility in a hanging drop preparation, serological test, agglutination with polyvalent anti-cholera serum. If positive for cholera, agglutination is checked with the Inaba and Ogawa strains antisera. Biochemical tests for identification are sugar broths and cholera red test with peptone water. Further agglutination with O1 and O139 antisera and other characterization tests. Control of an outbreak of cholera. In short, we will list the steps, some of which we will discuss in detail. Verification of diagnosis, whether the reported cases are actually due to cholera by the identification methods we have discussed in previous slides. If confirmed, notification of occurrence of cholera to the appropriate authorities. Early case finding, establishment of treatment centers, rehydration therapy, antibiotic treatment, investigation of the epidemic, what caused the outbreak, sanitation measures, and chemoprophylaxis if indicated. For the verification of cholera, we have to identify Vibrio cholerae O1 or O139 in the stools of the patient. If some of the patients test positive, it is assumed that the remaining ones with similar signs and symptoms are also cholera, and there is not necessary to culture stools of all the patients that report. If it is confirmed that the cases reported are actually cholera, the notification has to be made to the local health authority, and national government needs to notify WHO within 24 hours of its occurrence. Since 2005, this notification is not mandatory. The number of cases and deaths per day and per week are to be reported till the epidemic is over. Once it is confirmed that there is an outbreak of cholera, there should be a rapid case finding so as to prevent deaths in as many cases as possible, and establish treatment centers nearby so that no time is lost in providing treatment. They should be easily accessible treatment facilities. The mildly dehydrated can be sent home and given ORS. The severely dehydrated patients have to be transferred to the nearest treatment center, provided ORS during the way, and given IV once they reach the treatment center. If there is no pre-existing center nearby, establish temporary centers in local buildings like schools. Because transportation of cases over long distances may spread the infection and may make the outbreak bigger. In remote areas with poor health infrastructure, mobile teams should be established at the district level and dispatched as soon as there is any report of cholera outbreak. The rapid search for cases are now admitted and treated. The treatment includes rehydration, which can be oral in mild dehydration, and intravenously if severe dehydration is there. Antibiotics are to be given orally after vomiting stops. Parenteral administration has shown no special advantage in cholera. The commonly used antibiotics are fluoroquinolones, tetracycline, azithromycin, ampicillin, and trimethoprim sulfamethoxazole combination. Remember that antidiarrheal, antiemetic, and antispasmodics are not to be given. Also, cardiotonics and corticosteroids are not to be given. If no relief in diarrhea occurs after 2 days of antibiotic treatment, we suspect antibiotic resistance. Once the cases have been rapidly searched and the severe ones are treated, we need to investigate the epidemic. We get time to investigate the epidemic, to define the extent of the outbreak, to identify the modes of transmission which cause the outbreak, and to identify which control measures are to be applied to control the present outbreak. For assistance in this investigation can be asked from the following institutions. In addition to the early treatment and investigation of the outbreak, for further control of the outbreak, we should take sanitation measures to provide safe water for all purposes, drinking, washing, and cooking. This can be done by chlorination of the water or boiling, which the water is stored in narrow mouth covered containers. But the ultimately aim is to provide piped water on permanent basis to all the communities. Excreta disposal. Provide cheap, simple and effective sanitary latrines. We can choose the most practical method and use the help of local population for constructing these safe latrines. In addition, health education has to be spread so that people properly use such facilities regarding hand washing after defecation and the dangers of open defecation, etc., especially near the water source. Food sanitation has to be ensured. Health education is to be given for consumption of cooked and hot food. For cleaning the utensils after use, cleaning and drying. For disinfection, health education has to be spread. Disinfection can be both concurrent and terminal, and the most effective disinfectant is cresol. Bleaching powder is also an effective disinfectant if it is proven to be of good quality. What is to be disinfected? The stools of the patient, vomiters, clothes, and the latrines which has been used by the case, and the house and the neighborhood. Chemoprophylaxis has not been found to be effective on mass basis. Chemoprophylaxis is advised only for the household contacts or if the cases have occurred in a closed community. The drug of choice for chemoprophylaxis in cholera is tetracycline 500 mg BD for 3 days or a single dose of doxycycline. Vaccination is available against cholera. These are oral vaccines. Two types. One is Dukoral whole cell vaccine, which is monovalent. It contains killed whole cells of only Vibrio cholerae ovum, both classic and Eltor, and both Inaba and Ogawa. In addition, it has B subunit of cholera toxin. It is available as a 3 ml vial with bicarbonate buffer given as effervescent granules. This bicarbonate buffer is required to counter the gastric acidity so that the B subunit of toxin is not affected by the gastric acidity. 2 oral doses are given, and if the risk continues, a booster dose is given after 2 years, not to be given to under 2-year-old children. The other vaccine are bivalent, that is, it contains both O group 1 and 139. There is no toxin subunit, so no buffer is required, given in 2 doses 14 days apart and booster after 2 years.